Hi, I'm Susanna Valdez, and today I'm going to talk to you about psychomotor stimulants and ADHD. This is for the University of Texas of Arlington in partial fulfillment of the requirements of N5319, Advanced Pharmacology. Let's begin. So we want to look at our three learning objectives. We want to identify the drug class of the medication being discussed. We want to recognize the most commonly prescribed age group for the drug, and we want to discuss the possible adverse effects of the drug. So what is ADHD? ADHD stands for Attention Deficit Hyperactivity Disorder. It's identified by a reduced attention span and increased levels of impulsivity in children or adolescents in age and stage of development. Let's look at the pathophysiology of ADHD very briefly. The pathophysiology of ADHD points to evidence involving the dopamine and norepinephrine neurotransmitter systems in the brain. The global brain volume decreases by 3 to 5%. The gray matter is primarily affected in this volume loss. Then more volume loss can be found in the prefrontal area, the basal ganglia, and the cerebellum. If we look at the genetics, first-degree relatives of patients with ADHD are at an increased risk for developing the disease. As far as the environmental factors go, things that are pre- and perinatal are affected. Things like stress and smoking, alcohol intake during pregnancy, and a low birth weight can also affect if somebody is going to be predisposed to ADHD. Then let's talk about diagnosis of ADHD and the three attributes of it. So first, it's distinguished by three different attributes. We have overactivity, which is gross motor. We have impulsivity, and we have inattention. With the diagnosis of ADHD, there are no lab tests that are available. It's based off of a clinical interview with a physician, and then assessment scales are used. These are completed by the parents and by the teacher or teachers. There are some non-pharmacological interventions that you can do for ADHD. These include a healthy diet, exercise, and then also cognitive behavioral therapy in conjunction with pharmacological therapy. So now we're going to talk about our drug of choice. It's methylphenidate. Its drug class is a CNS stimulant, also known as a psychomotor stimulant. It's more commonly known as Ritalin, that's its name brand. Its mechanism of action is that it inhibits the transport of dopamine and norepinephrine. This leads to an increase of both neuromodulators in the synaptic cleft. Now on this next slide, it's showing you how this happens. So I'm going to take the mouse and show you. So the green that we have right here, this is going to be the norepinephrine, or if you see on here, it says noradrenaline. Those are synonymous, they're the same. Then the dopamine is going to be right here in the yellow. And then this right here is the dopamine transporter, or DAT. The green one that you see, let me get my mouse right there, that's going to be the noradrenaline transporter, or NET. And then if you see this orange on here, this is the methylphenidate. And so it is attaching to there, and it's keeping it from having a reuptake of this into the synaptic cleft. So see, here's your free dopamine and your free norepinephrine, or as it's listed here, noradrenaline. And we are going to block that reuptake. Okay. What age group is commonly prescribed methylphenidate? That's one of our learning objectives. So the FDA has approved it for children 6 years of age and older. It's most commonly prescribed to children and adolescents, and the ages are 6 to 18 years, and it can be used into adulthood as well, and adults can also take it. Standard dosing. You're going to start with a dose of 5 milligrams twice a day before breakfast and lunch. The dose may be increased 5 to 10 milligrams a week, with the max dosage being 60 milligrams per day. The optimal dosing of methylphenidate depends on some different things. So we're going to look at a variation of genetic factors, age, weight, sex, drug tolerance, and interactions with other medications. The administration routes. So it's mainly in an oral form. We have an oral tablet. There's a short acting one. That's what most patients are started out on. Then there's also a long acting extended release as well. The oral forms come as chewable. You'd use those in smaller children, 5 to 6-year-olds that can chew but can't swallow pills. As they get older, they can take a tablet. There's also disintegrating and capsule. And then it's also available as a transdermal patch. The efficacy of methylphenidate. Long-term use has proven effective. There was a research study, and the drug was still effective after continuing methylphenidate for 2 years. It did say, however, in the research study that you want to discontinue it periodically to reassess for continued need. Then we look at the pharmacokinetics of methylphenidate. The absorption is very rapid because it's taken orally most times. The peak time is going to be between 1 to 3 hours. Its half-life in children is 2.5 hours, and adults it's 3.5 hours. The elimination, it's excreted chiefly through the kidneys, and the remaining amount is excreted through the urine. Challenges to treatment. You're going to have mild to moderate side effects, inadequate compliance, and halting treatment with high dosages. These are some of your major challenges. However, the most common reason for discontinuing treatment is adverse side effects, which is our third learning objective, and we're going to discuss that next. So let's look at the adverse side effects. The most common of these are going to be abdominal pain and nausea, insomnia, and nervousness. There are other adverse side effects responsible for drug discontinuation, though, as we just previously discussed. They're going to be things like headache, decreased appetite, dry mouth, nasopharyngitis, and irritability. Now let's look at the contraindications of methylphenidate. So contraindications are going to be in patients with epilepsy. This is because it may increase seizures. Also in patients with glaucoma, because of the mechanism of action, it can increase intraocular pressure. Methylphenidate can interfere with the metabolism of warfarin, phenytoin, phenobarbital, and tricyclic antidepressants. So some precautions that you want to take with methylphenidate. It's a Schedule II drug. What does this mean? This means that there's a high potential for drug abuse and also drug dependence, which means you have to get the dose higher and higher to achieve the mechanism of action needed. So let's look at that. Signs of drug abuse with methylphenidate. So you're going to watch for things like an elevated heart rate or blood pressure, dilated pupils, hyperactivity, restlessness, tremors, psychosis, hostility, aggression, and suicidal or homicidal ideation. These are signs that the drug is being abused and needs to be discontinued and tapered. So expected outcomes. What we want to see is an increased attention span, impulse control, and improved academic performance. So in conclusion, now I'm going to have the class, the bachelor nursing students, complete a case study. Then we're going to do a group discussion, and then we're going to have 3 questions to consider, which we will go over together in class. Then we're going to complete a 5-question non-graded quiz. There will be a group discussion of this quiz as well. There's going to be an emphasis on the correct versus the incorrect answers with the rationales. This concludes this presentation. I hope you enjoyed it, and I hope you learned a little something more about methylphenidate. Thank you.